sir has rightly pointed out, the height failure with the preserved ejection fraction is a little ambiguous entity where the diagnostic and therapeutic avenues are still not properly explored. But sacubitril valsartan across the ejection fraction, if we see the data, outpatient with reduced ejection fraction paradigm HF and then titration trial, then to in hospital patient admission, improving, stabilizing and discharge, pioneer transition and paraglide heart failure trial, and post hospitalization paragon heart failure trial. So benefits were observed across the spectrum of the patient, including the chronic patients, acutely hospitalized patient, and post discharge patients. Now, getting the best out of the sacubitril valsartan in different heart failure patient profile, chronic HFrEF patients, hospitalized HFrEF patient, de novo newly diagnosed HFrEF patients, elderly HFrEF patients, heart failure with medium range ejection fraction patient, that is between 30 to 45% of ejection fraction, and heart failure with preserved ejection fraction. So obviously the data which suggests it's more benefit in terms of mortality reduction and symptomatic benefit in heart failure with reduced ejection fraction of all category, chronic, hospitalization, hospital patient, de novo diagnosed, and elderly patient, and heart failure with medium and preserved ejection fraction data is still in under exploration or in a medium range. So role of heart failure in HFrEF patient. Next slide. Initiation of the ARNI helps in HFrEF patient to live longer and stay out of hospital. That has been well documented. All primary composite endpoint, including cardiovascular death and heart failure hospitalization, was significantly lower than the enalapril arm in the major paradigm HF trial. Next, role of sacubitril valsartan in hospitalized HFrEF patient. Again, it reduces the risk of cardiovascular death or rehospitalization for heart failure in hospitalized patient with the HFrEF patient. So earlier there were concern when to start the ARNI in should be started in a convalescence bed after discharge or in an acutely hospitalized patient. Now it's clear from some of the trials that we can start in hospital also the ARNI if the other metabolic parameters are favoring and the hemodynamic parameters are favoring. There is 42% reduction in cardiovascular death or rehospitalization with the sacubitril valsartan compared with the enalapril. Next slide. Now, role of sacubitril valsartan in de novo HFrEF patient. In de novo HFrEF patients, ARNI patient stays out of hospital and lives longer. Again, the same modality and same benefits were observed. Patient on ARNI had a significantly lower incidence of composite of cardiovascular death or rehospitalization for heart failure in a hospitalized patient with de novo heart failure. Next, early initiation with sacubitril valsartan keep hospitalized HFrEF patient alive or live longer. There is trend toward reduction in death up to 46% with initiation of the sacubitril valsartan was observed in hospital patient without prior exposure to S or ARB. So when you are documented HFrEF patient, now the norm is now we need know SARB are out and we need to directly start with the ARNI. Almost like you need to be vigilant regarding starting with the low dose and escalating into the guideline recommended dose in slow and a graded manner because our Indian patient have less tolerance to reach to that 200 milligram BD dose. Next slide. The real world evidence of sacubitril valsartan in octogenarian elderly patient with the heart failure results of parachute heart failure study. Again, that study demonstrated it's a equal benefit as compared to the patient those are not in octogenarians in terms of cardiovascular death reduction as well as heart failure hospitalization. Again, like we need to be cautious regarding monitoring the serum potassium level and renal function test and patient's hemodynamic in terms of blood pressure. Now, real world evidence of sacubitril valsartan octogenarian elderly patient with the heart result from the parachute study. Again, it's a significant reduction in the anti-proBNP level in heart failure patient both under and over 8 years of age with comparable discontinuation rate. This finding again highlights the effectiveness and safety of RNA in management of the chronic heart failure in elderly, offering the valuable real-world evidence. Next slide. Now, another subset, that subset number 5, heart failure in with the mid-range ejection fraction with ion preserved ejection fraction. There are small-scale study with less power near for 500 patients, stable patient is more than 18 years with diagnosis of heart failure and ejection fraction of more than 50% and elevated NT-proBNP or B-natriuretic peptide level. It was double-blind randomized control trial and primary outcome was time average proportional change in NT-proBNP from baseline to week 4 and 8 weeks. Paraglide heart failure trial. Now, if we see the primary endpoint, there is 15% greater reduction with this RNA group versus the control arm, and among the patient with ejection fraction more than 40% stabilized after primary treatment. RNA lead to greater reduction in the plasma NT-proBNP level was associated with the clinical benefit compared with the Valsartan alone. So this area is still underexplored, but the data is promising in terms of like medium category ejection fraction. The things looks promising. Next slide. Any renal outcome across the spectrum of the heart failure paradigm heart failure trial, benefits in heart failure with reduced ejection fraction, and renal outcomes in paradigm paraglide heart failure and paragon HF benefits in heart failure with the medium ejection fraction and preserved ejection fraction, and there is 40% risk reduction in the renal composite endpoint.